What's interesting about the afternoon session is that it's not purely economics or monetary policy. It really underscores, I think, the challenges that we are seeing today. So we'll have different topics, long COVID, climate change, geopolitical issues. So the first one will be on long COVID, and the moderator is Olivier Garnier. Please go ahead. Thank you.
Okay, thank you, Kathleen. And so I'm very pleased to open this session, at the start of the afternoon. So the title of this session is Long COVID Research, Policy, and Economic Impact. So, just before starting directly in this topic, but just to show that COVID is still with us, Anna Paulson, Director of Research of the Chicago Fed, was supposed to be with us, but just before going to France, she was tested positive. So you see, there is still some effects of COVID, but we have two outstanding panelists to talk about COVID. During this crisis, maybe during the COVID crisis, very often we could hear on the TV doctors talking about economists and economists talking about epidemiology. So we have the chance today to have both a physician and an economist, and they will Andrew Racine, Racine, I don't know if we pronounce in the French way, with Senior Vice President and Chief Medical Officer at the Montefiore Health System and Executive Director of the Montefiore Medical Group in New York City, and Gilles Moëc, the Chief Economist of AXA, the AXA Group, the insurance company. So what we will discuss, in this session is maybe the long COVID. You may have a medical interpretation because now long COVID, I think I'm speaking under the control of a doctor. Long COVID is, the fact that some people we have suffered COVID have lasting, have lasting effects, suffered from lasting effects of COVID. But I think and for sure also COVID has also some lasting effects on the healthcare system more generally. So maybe I'm sure that Andrew will start on this topic, and then we will discuss also the lasting effects of COVID on the economy, the lessons that we can draw from the policy response to COVID, and maybe since we have many US friends in the room, maybe also discuss the difference in policies that were implemented in the US and in Europe, and with the benefit of hindsight, what we can say about the differences. So we start with Andrew. You have the floor is yours.
Thank you, Olivier. I wanted to begin by thanking the Global Interdependence Center and the Banque de France for allowing me to participate in today's session. It is the first and probably the last time I'm going to share a podium with the governor of the Banque de France, and it's an extraordinary honor, I have to say. So my job here is to talk a little bit about the medicine, and I'm going to be talking, the title of this talk is A Season in Uncertainty. This is a reference to a very famous French poet, Arthur Rimbaud, who wrote his masterpiece, Un Saison d'Enfer, when he was about 17. We're going to be dealing a lot with uncertainty. I know that the people in the audience who are in economics, and particularly in the policy realm, are used to this issue of uncertainty. In medicine, it makes us quite uncomfortable, but there's a lot of it that we are dealing with. This particular part of the segment, I'm going to begin with some things that we know well, that is, things that are less uncertain with regard to this disease, and progress from there to talk about long COVID, which is fraught with uncertainty. My only consolation is that my difficulty in dealing with uncertainty is nothing compared to what Gilles is going to have to do when I get off this podium. So let's begin with what we do know. This is a little bit of a review about what COVID is. I don't expect people who came to this session thought they were going to have to deal with molecular biology, but here we are. So what is COVID-19? This is a disease that's caused by an infectious viral agent. It's of a family, what we refer to as SARS-CoV-2, and essentially it looks like this. This is a very, very primitive thing. It's not clear to us that this is really a living thing at all. What distinguishes those of us in the audience from the seats that we're sitting on is our ability to make high-energy phosphate bonds, and those bonds are used essentially to drive a variety of different metabolic activities within our bodies. Well, this thing can't do that. It cannot reproduce itself. It cannot make high-energy phosphate bonds. All it is a set of instructions, which is in the middle of this thing. Those instructions are encoded in a molecule called RNA, and all those instructions do is to be able to replicate what's there. So you've got these instructions that are sitting in a capsule that's made mostly of lipid, but on the outside of that capsule are a series of proteins. The reason that's important is because that thing, in order to do anything at all, has to get into a living cell. That living cell has the mechanisms to reproduce it, but the virus itself can't do that. So these proteins allow the thing to get into the cell, particularly those red proteins called spike proteins, which is on the virus. They attach to things called ACE receptors, which are on the surface of human epithelial cells. And that attachment allows the virus to open up a pore in the surface of the epithelial cell and inject itself into the cell, whereupon it can take over the mechanisms of the cell for its own purposes. So if we were to blow up a picture of those spike proteins, this is just an enlarged pictograph of what you saw on the left-hand side. You've got that red thing, which is this spike protein sitting on the surface of the virus, which is on the top. And then you've got this blue ACE receptor, which is sitting on the surface of the cell. And that's how this virus gets into the cell. What else do we know about this? Well, those ACE receptors are ubiquitous throughout the human body. And that has implications for what happens when we get sick with this particular virus, because it goes all over. And so the virus can affect almost every organ in the body, and it does so through two principal mechanisms. Number one, it can kill cells itself, and so the destruction of cells has implications for how we feel when we're infected with the virus. But the other thing is that the body itself mounts an immune response to the presence of the virus, and that immune response also has implications with regard to how we feel. The reason that's important is that the therapy that we apply to infections with COVID-19 correspond to that. In the beginning of the infection, we give people antivirals, which are designed essentially to minimize the number of viruses floating around. But after a while, in the course of the infection, we apply steroids, which are responsible for trying to tamp down the body's immune response in order to make sure that we don't overreact to the presence of the virus. Finally, there is prevention and moderation, and that relies on building immune protection. We use vaccines, we use monoclonal antibodies, and that's how we treat this infection. So that's COVID. The next question is, well, what is long COVID? And the answer to this question depends on who you ask. If you ask the CDC, the Centers for Disease Control and Prevention in the United States, CDC defines long COVID as the occurrence of new, returning, or ongoing health problems 4 or more weeks after an initial infection with SARS-CoV-2, the virus that causes COVID-19. So their definition begins at 4 weeks. If you ask the National Institute for Health and Care Excellence in Great Britain, their definition are signs and symptoms that develop during or after an infection consistent with COVID-19 that continue more than 12 weeks and are not explained by an alternative diagnosis. So they don't use a 4-week cutoff, they use a 12-week cutoff. And the other thing is that they talk about an infection consistent with COVID-19, and that covers an awful lot of territory. And then finally, we have the WHO, and the WHO's definition is more in keeping with what they're using in Great Britain. It's a condition, quote, that occurs in individuals with a history of probably or confirmed SARS-CoV-2 infection, usually 3 months, that's 12 weeks, from the onset of COVID-19 with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. So the WHO requires not only that it be at least 12 weeks since your initial infection, but that the symptoms last another 2 months, and they're the only agency that has that. So when we talk about symptoms for COVID-19, long COVID, what is it that we're talking about? So there are certain neurologic symptoms that we refer to: headache, loss of sense of taste or smell, memory difficulties, concentrating, that kind of thing. There are respiratory issues. Obviously, this is a respiratory, predominantly a respiratory virus, so there's a cough, dyspnea, which is the subjective sense of difficulty breathing. Sometimes X-ray abnormalities are included there. We have mobility issues, that is essentially decreased exercise tolerance, mental health, PTSD, post-traumatic stress disorder, anxiety, depression, sleep disorders, and then general symptoms: weight loss, pain, fever, fatigue. And finally, a couple of things that are of interest: the increased likelihood of developing diabetes or chronic kidney disease. So those are the symptoms that are associated with it. In addition to that, it's important to understand there are certain characteristics of the symptoms I just mentioned that have implications for our ability to really understand what the prevalence of this condition is. The first point is that most of those symptoms are self-reported. In addition to that, they are nonspecific. And finally, they're common. So when we're dealing with things that are self-reported, nonspecific, and common, our ability to distinguish what is long COVID from what is who knows what else becomes somewhat murky. And this is where a lot of the uncertainty begins. The response to that is certain epidemiologic studies that we try to use in order to understand what is happening with the prevalence of long COVID. So for example, when we do these epidemiologic studies, we have to worry about who we're including and who we're excluding. And depending upon the study and who's conducting it and where it's conducted, there are different inclusion and exclusion criteria. And depending upon whether or not you include certain people or not, you're going to end up with very different prevalence estimates. So those studies that predominantly use people who've been hospitalized come up with a very different set of estimates than people who are using free-living populations. In addition to that, there's the time period of infection. So you've seen that some people define it as anything from the beginning of the COVID infection right through to 4 weeks or 12 weeks. Depending upon the time, you're going to end up with different prevalence estimates. Symptoms that are included in the analysis. I already gave you a whole list of symptoms. Some studies use a selected subgroup of those, some use all, some use radiologic studies, some do not. And depending upon which symptoms you use, you get different prevalence estimates. The source of the data. I just talked about the fact that there are issues with regard to whether or not people are hospitalized. There are some studies that use specific organizations that people who are known to have had COVID, to ask them to do surveys for them to find out what the prevalence is. Well, if you're restricting yourself to people who belong to some of these kinds of organizations, you're going to get a very different set of estimates than if you do free living populations. And the same is true, for example, there are surveys that are done on Veterans Administration organizations. This is because it's easy to get those data, but veterans are very different from other people. The comparison groups. So if you want to know whether or not what you're dealing with is only long COVID, it would help to use another group of people that have a similar condition, not long COVID, but another condition like long COVID, to see whether or not those people have the exact same symptoms. Because if they have the same symptom profile, it's very difficult to say that this is specifically because of long COVID. And finally, subgroup analyses. How does this age group compare to that age group? How do people who have pre-existing conditions compare to people who do not? The response in terms of epidemiologists is to conduct studies in different ways. The first are what are called meta-analyses, and these are simply collections of lots of different surveys done by different people at different times that are pooled together in order to increase the precision of the estimates and in order to also get a broader representation. So I'm going to give you a couple of examples of meta-analyses. The alternative to that is to get a long case series, that is one study looking at lots of people using the same criteria and the same symptoms that may give you a little bit more of a precise estimate, but may not be as broadly based. And finally, there are case control studies, which again have comparison groups associated with them. But the gold standard would be population studies, where you go to a free living population and you try and get the best estimates that you can from that. So what do we know about the prevalence of this condition? Well, I'm going to give you a couple of examples of these meta-analyses. Here's one that was conducted by a group out of Stanford University, and they essentially looked at 47 studies that were covering about 9,700 individuals. These were survivors of COVID infections, most of which had been hospitalized, and are studies that are published between 2020 and 2021. This is important because the vast majority of people with this condition do not end up in the hospital. If you are going to construct estimates of long COVID on the basis of hospitalized individuals, you're going to get a very different set of prevalence estimates than if you use people who are not hospitalized. A second group, these are folks from Penn State, did a similar thing. They did a meta-analysis in which this time they looked at 57 studies, over 250,000 people. And they were also survivors of long COVID. And again, about 80% of them were people who had been hospitalized. These studies were also published in 2020 and 2021. And I'm going to show later on how the pandemic has matured over that period of time. So our estimates of what's going on with long COVID will change as the pandemic matures. Finally, we have, this is not a meta-analysis, but it's a single study. It's a large study of about 273,000 people with COVID-19. And these were patients that were retrospectively queried about the existence of these 9 specific symptoms. So what did these folks find? Well, if you take a look at this first study, this is the first meta-analysis that I was referring to. This essentially shows you what their estimates were of a variety of different symptoms that are along the left-hand side. You can see them all listed there. And the only thing that I want to point out with regard to this is that each of those dots represent a different study in this meta-analysis. Remember, there were 47 studies there. And depending upon which of the symptoms you are referring to, some of them are actually very, very common, and some of them are very, very rare. But all of them have these enormous spreads associated with them. These are box charts, which essentially means that that black line in the middle of the box is the median of all of these different studies. The box itself represents any place from the 25th to the 75th percentile. And you can see that, for example, if you look at the estimate of fatigue, which is a self-reported, very vague, very common symptom, it's all over the place. You have people that are estimating it to be maybe 5, sort of 10%, all the way up to 75%. It's very difficult to get a precise estimate on the basis of this kind of thing. The same is going to be true if we look at the results from the second study. And this, again, is, box plots, but they're done vertically as opposed to horizontally. And this is for all symptoms, not simply the ones that I listed on the left-hand side. And what you can see here, essentially, is they've divided it into what are called short-term in the first 30 days, medium-term, intermediate term, which is between 30 days and 90 days, and then long-term. And regardless of where you look at that, their estimates are that about 55% of people are going to have some symptom of long COVID, either in the short, medium, or long term. But again, the spreads are quite enormous, as you can see in those intermediate term time periods. So the precision of these estimates is still something that is difficult to determine. This final study, which is an interesting one, takes a look at those 9 symptoms which I referred to before. Again, this is not a meta-analysis, it's just a large study. And you can see, again, depending upon which symptom you're looking at, you have different estimates. The light pink areas here are people who only had those symptoms during their acute illness, first 30 days. The darker pink estimates are people who had them between 90 and 100 days, 180 days, or greater than 180 days. And again, there's huge variation with regard to this. The interesting thing about this study, though, is they used a comparison group. They looked at people with influenza. And if you take a look at that, you find something quite interesting. Here's the spread, essentially, of people from intermediate, meaning after 90 days onward, who developed symptoms of long COVID in pink. But the line in blue represents those same symptoms, but for people who didn't have COVID, but who had influenza. And what you can see on the basis of this is that it may be that 45, even 50% of people were estimated to have the symptoms from long COVID, but 30% of them had them just from influenza alone. So unless you're going to use a comparison group, you're going to end up with estimating things that may not be specific to this condition. The final thing that I just want to show you is this is a study out of England, and this is essentially a population-based study. What this demonstrates along the x-axis are different age groups. Along the y-axis are the percent of those age groups in the entire population that have these symptoms. And it changes over time as the pandemic matures. But you can see even the age groups that have the highest percentage of this, we're only talking about 3 or 3.5% of the population who end up having these symptoms. And that's just to give you a sense that while we concern ourselves with long COVID, over the long term, it may not actually be that much of an issue for us. The final thing that I just want to talk about are two things. One is the timing of this pandemic, because things have changed since the start of it. We began with the identification of the virus, which was in January of 2020. And then there were steroids that were recommended for the treatment of this by the fall. Right after that, we had the development of antivirals in remdesivir, which was also added to our panoply of treatments. And then by December, we had an effective vaccine. I cannot begin to tell you how extraordinary a scientific achievement it is to go from the identification of an organism in January of a calendar year to the successful development and marketing of a vaccine for that by December. This is equivalent to the moonshot is what this is. And we take it for granted, but it is an extraordinary accomplishment. The second year, what we had essentially is the development of a variety of different variants. And this is important because it changes the scope of the pandemic. We had the Delta variant in the summer, the Omicron variant that began in the fall. We then finally developed oral antivirals by December of this past year. And finally, we now have pre-exposure prophylaxis. The reason I bring this up is because what's happened now is that the pandemic has changed, our treatment has changed, therefore the likelihood of developing long COVID has changed. And just as an example of that, we have an article in the New York Times not a couple of weeks ago that showed, that asked the question, do vaccines protect against long COVID? And they reviewed 6 studies, none of which actually have been published yet. They're not in the published literature. But 4 of the 6 seem to indicate that yes, the advent of vaccines really has changed the likelihood that people are going to develop this. And so I'm just going to finish with an anecdote because I think it gets to the issue of what we're doing when we're faced with the kind of uncertainty that I've talked about. I did my training in pediatrics in Boston many years ago, and I was at the Children's Hospital there. And when I was in my first year of training, I was rotating through the neonatal intensive care unit. The NICU is the place in the Children's Hospital where we take care of the sickest children. So as a consequence of that, the uncertainty with regard to outcome is the greatest in that setting vis-a-vis other places in the hospital. And we were caring for a specific child, I remember, who actually had been in the sick part of the NICU, meaning where the children are intubated and monitored on a minute-by-minute basis. And she had graduated from there to this other part of the NICU where we have what are called feeders and growers, children who no longer need to be monitored by minute, but are just gaining weight enough so that they can go home. The thing that was interesting about this child is that she was dysmorphic, which is to say that she had facial features which suggested that she had some kind of a genetic abnormality. We didn't know what it was, we didn't know what it was going to mean, but it was clear on the basis of how the child looked that she had something like that. We were having a family meeting. This was a young couple. This was their first baby. I was in that meeting along with the senior resident, who was my supervisor, and then the fellow who was supervising the senior resident. This was a couple who were being buffeted about, as you can imagine, by their own concerns about this baby, about what their families were telling them, their friends. And they asked in the course of that meeting, well, is she going to speak? Will she walk on time? Will she be developmentally normal? And there was a silence in the room. And I said to them, I said, well, that's actually not the right question. The right question, the only question, is whether you think you can love this baby. Because if the answer to that is no, it doesn't matter if she stands up and walks out of the NICU tomorrow reciting Shakespeare's Henry V soliloquy. But if the answer to that is yes, then you are going to contribute to the development of this baby in a way that no one else can do, and is going to have the greatest impact on her development over time. which is affective input into who she is. So concentrate on what you have control over. That is a choice that you can make. Make that choice, and then the future will take care of itself. And that's where we find ourselves now in this pandemic. There are things we know we can do. We know that work. Getting vaccinated, wearing masks, avoiding crowds, practicing hand hygiene, and if you get sick, getting treatment. These are choices we have, we know. They're in our control, they work. And my only plea is that if we do that, if we concentrate on what we can control, the future will take care of itself. Thank you.
Maybe just before turning to the economics of COVID, maybe one question about do you see some kind of already some change in the way hospitals work in the US are organized due to COVID? You know, what would be the kind of long-term implications of COVID on the way the healthcare system more generally is organized, or the way also to maybe to the difficulty now to find people to work at the hospital. Do you see already some changes?
Yes, there are huge changes in the healthcare industry, just as there are elsewhere. And the healthcare industry monitors or sort of reflects many of those changes. One of the things that that Olivier is referring to is the difficulty with regard to the workforce. This is something that may have been a trend that we were seeing earlier on, but the advent of COVID has made it that much more accelerated. It's a very difficult thing sometimes now to hire and to recruit skilled nurses in particular, because this has become a profession which is much higher risk than anyone ever thought it was when they're first going into this. So we have early retirement for people who no longer want to take those risks. We have reluctance of people to come into the profession, and we have demand for higher wages in order to accept those risks, all of which you can understand makes sense from a labor market standpoint. That's just one aspect of this. There have also been changes with regard to the use of telemedicine, which we know about, which is all throughout all industries, but in medicine in particular, we've been finding ways to use it particularly for mental health issues, but for other things that we never thought we were going to use it for. And then finally, how it is that we essentially run these institutions with regard to which supplies we think we need and how many of them we need to have on hand. When this first happened, everyone was caught short with regard to PPE, with regard to things that we needed for respirators, with regard to things that we needed for dialysis, and no one is going to be in that condition again for some long period of time.
Okay, thank you. So maybe now we can turn to the economics of COVID, and maybe during the discussion at the end we will get back to the healthcare implications. But so Gilles, now the question would be, in the same way that some people are suffering from long COVID, could we say that the economy also is suffering from long COVID? That means with some kind of scares, or what are the long-term implications of COVID? Are we completely out of this crisis? And also, what kind of lessons can we draw from the policy responses to this crisis? And what were the bad or good policies?
Thanks, Olivier, first of all, for inviting me. And just one point before jumping into the economics, Andrew's last point in particular reminded me that there are people who deal with this on the front line, who have to deal with it in life and death situations. We are in a much more comfortable position, but from time to time we may have an impact on how policymakers do react. And we should just really be reminded that whatever we propose as solutions, there are people on the front lines who will have to deal with it. So I just wanted to start with this. Okay, I'm not going to distribute positives and negatives on national policies. Anna Paulson is not going to be with us, but that will allow me to speak ill of the Americans, obviously. So you will allow me a bit of leeway there. Okay. Dealing with, I don't know how to call it, short COVID, I mean the first outbursts of the disease. I think in terms of policy reaction, we've had, generally speaking, in the developed world, an incredible quality of response. Maybe because we learn from the mistakes from past systemic crises. We learned, I think, enormously from the great financial crisis of 2008, 2009, and we had immediately a level of commitment from fiscal and monetary policy, which has really stopped the crisis in its tracks, if I could describe it this way, which I think has really minimized the scarring effect on our economies. Basically, what we've done is that we made sure that what started as the epitome of the supply-side shock, all of a sudden production stops in a number of key sectors, and we had to make sure that this supply-side shock would not turn into a demand-side shock, because we would be able to protect income and profits, and both wage earners and companies could actually continue operating at a decent pace without massive losses. And it was achieved by fiscal policy, and without too much debate. I think that is maybe an area of surprise there, is that the decision was made extraordinarily quickly in February and March 2020 that we needed to provide a level of fiscal response which would basically keep income intact. That's what we did in the US, that's what we did in Europe, without much of a debate. I think to some extent the reason why there was not a lot of a debate is that before the crisis started, we had had 10 years of intellectual rehabilitation of fiscal policy. In my days at Banque de France a long time ago, probably, and what I learned at university as well, in the late 80s, beginning of the 90s, was the idea that fiscal policy was a bit of an also-ran, right? I mean, it was not the prime response to any shock. Monetary policy would be the prime response to any shock. We made a collective mistake in 2009, 2010 by moving to austerity policy too quickly after the recession. And we learned that by doing this, we would actually prolong the pain. And because we had rehabilitated fiscal policy after 2010, I think we came much more quickly to the conclusion that we need to provide an enormous amount of support. And monetary policy did the rest. Honestly, and I know I speak at a forum organized by a central bank, but I don't think that monetary policy played a major direct role in dealing with the pandemic, but what it did, it made the fiscal response possible. It made the fiscal response sustainable, and that's absolutely crucial, and that's absolutely key. Since we've been able to stop most of the demand-side ramifications of the crisis, I think we end up with a level of scarring of our economy, which is actually quite limited. And I confess that I was completely wrong on that. In the middle of the pandemic, I was absolutely sure that there would be such a loss in job opportunities, in particular in investment, that we would have to, we would be dragged by the crisis for years and years. And what we've discovered actually is that the investment rate of the corporate sector did not fall that much during the crisis. I don't think the stock of capital has taken such a big hit. And productivity might have improved. Might, because honestly, I don't know who in his right mind today would be able to measure productivity in a proper way, given the volatility in the data we've had over the last 2-3 years. But maybe the acceleration in digitalization has triggered an acceleration in productivity. Now, what did not work as well, or that well? And this is where I will start to speak ill of the Americans, on two fronts. One, I think it's fair to say that the fiscal support, which for me was absolutely crucial, went too far in the US, to the point that by the end of the acute phase of the pandemic, the US was in a situation of overheating, was triggering demand-side inflation, and from this point of view, Summers was absolutely right. The last installment of the fiscal push was wrong, went too far, and triggered a level of inflation which is forcing the Fed today to start turning the tap off, and this is not ideal. The second point, which I think is problematic, and also, again, it's speaking ill of the Americans a little bit, is the way the labor market was treated. What we did in Europe, because that's our social consensus, is that we made sure that the legal relationship between employees and employers would not be severed during the crisis, and we kept people on the company's payrolls. And when the economy normalized, we didn't have this massive churn of the labor market with people forcing to find something else. In the US, the severance of the legal link between employers and employees is now triggering this massive churn of the labor market, which is probably one of the reasons why wages are accelerating that much at the moment, feeding inflation, and again, forcing monetary policy to react. That gets me to my second point, which is where we are now and what could we do if we were to deal with either another outburst of acute COVID or with long COVID. Where I think that we have some scars, it's on the policy space that we have left at our disposal. In the sense that demand for protection at the moment from citizens, from their governments, is almost infinite. They want protection against the usual traditional risks, the medical risks, at least in Europe, unemployment, aging. We still need to deal with a structural increase in public spending coming, for instance, from aging. And we have this new requisite from citizens, which is please do something about global warming, but please protect me against any impact of the fight against global warming on my personal income. And that's another source of massive demand for fiscal action. And on the other side, we have governments which have seen an enormous increase in public debt for good reasons during the crisis. And it's become much more complicated to accommodate this public debt because fiscal policy is basically saying that maybe it's time to stop fooling around. If we have long COVID as a structural feature, one possibility, and Andrew was very thorough in his approach, mentioning how complicated it is actually even to put numbers and even to put a name, to put a definition on the problem. But let's say that we have a percentage of the population, 3.5%, which would be incapacitated, in some shape or form for the rest of their working life. How would this actually affect our economies? Maybe it would affect us via the supply of labor, and that's not good for potential growth. Maybe it's going to affect us via productivity, with a number of people whose capacity to work at 100% would actually be lower. How do we deal with that? And this is where, and that's my conclusion, everything we've put in place during the crisis in terms of response has been geared towards dealing with a sort of gigantic cyclical shock. It's been geared towards dealing with a massive and transitory loss in activity, in income. If we have to face a sort of long, debilitating pressure on potential growth, then as usual, there's not much monetary policy we'll be able to do about it, and maybe fiscal policy will be able to do something about it via investing in new technologies and so on and so forth. But the room for maneuver to deal with this, our policy reserves, are unfortunately at this stage very, very depleted. So I would give an A star actually to how we've responded to the crisis in 2020 to 2021. I'm not sure I would give more than a C- on our capacity to deal with either a return of the same type of pandemic or with debilitating long-term visible impact on potential growth. Stop here.
Thank you, Gilles. Maybe just before going into the Q&A, we will have a few minutes, but a question to both of you, to both the the physician and the economist about China, because China is the elephant of the room because China is not out of COVID. There has been this the zero COVID policy. So what is your assessment, both as a physician and as an economist, of this zero COVID policy? How successful it was? It was also implemented in some other countries, often in some islands or big islands like Australia. But we know that as economists, sometimes when you have a policy like a currency, a peg, or whatever, it's difficult to exit. And you have the same dilemma. If you exit too early, the pain that you have suffered before could be completely lost, but there is a risk of also exiting too late. So what's your assessment first, Andrew, and then Gilles?
So is this on? Yeah? I'm going to leave to Gilles the discussion about the economic impact on China. But from an epidemiologic standpoint, so China made an interesting decision, as did other countries, as Olivier mentioned, to try and avoid the exposure to COVID at all in the beginning. And interestingly, because it was the place that the virus first emerged, but they also had politically the opportunity and the capacity to do that. In the beginning part of the pandemic, there might have been some rationale to that, insofar as you could buy yourself enough time for the vaccines to be developed so that you could then protect your population by vaccinating the entire population. The problem for China is they developed a vaccine that wasn't particularly effective. And so they vaccinated a whole lot of people, but it didn't have the impact, the epidemiologic impact that they anticipated. The estimates are that there are about 500 million people who've been infected with this virus up until now, and that's a vast underestimate. It's probably 3 times that, maybe a couple of billion people. That's the bad news. The worst news is that there's still another 5 billion people that haven't been infected yet. And they are a pool of people that can still get this disease. So we have a long, long way to go before this particular organism has worked its way through the human population, and it's shown its ability to reach every place. So my feeling about China is that if they could get themselves an effective vaccine, then their initial idea about this was not a bad one, but I'm not sure that that's actually going to happen.
Yeah. My recommendation on exiting policy is always exit very, very late, but that's for another conversation which took place this morning. On China itself, my first reaction is that we've had very, very different tolerance to risk and to the mortality risk across countries throughout the pandemic. And again, speaking from sort of European seat, and I'm usually in the UK, the tolerance for risk was significantly higher in the US than in the UK, and probably higher in the UK than on the continent. And I don't want to get into the cultural reasons behind this, but there are differences. And Sweden is another case in Europe. And if you look at the mortality rate, cumulated mortality in the US relative to Europe, 2 years into the pandemic, the difference is striking. So there are clearly some countries which accept a level of lethality given the price to their economy, which is very, very different than what you would find in another one. In the case of China, we don't know. We don't know what is the social tolerance to risk, because the government, in its usual fashion, started from day one on this zero COVID policy. And exiting from this policy is now extraordinarily costly because, and it has been reaffirmed actually yesterday in a speech to the Politburo by Gilles, because the leader is now identified as the guy who's actually defended that policy. But there has been no proper social choice on this. You could argue that in the US, in Europe, there has been some measure of social choice on the level of infringement on individual freedom in particular, and on the level of economic cost that countries could accept. This has not happened in China. So in a way, the Chinese government is now blind as to what it could do next. Apparently, it seems that the acceptability of the zero-COVID policy is falling dramatically. We've seen those images in Shanghai and other places. People just don't accept the drastic limitations to mobility. But truth is, no one, and probably not the leadership itself in China, knows where is the bar. So if I talk to my colleagues in China, what they tell me about the situation there is that there is some thinking about a sort of halfway house. Let's try to move away from the most drastic limitations to try to preserve as much as possible, first, the social well-being of people, and second, the state of the economy. The big problem with this is that if you look at the vaccination rates across age in China, in a way, it's the reverse of what we have in the West. Apparently, there's only slightly more than 50% of the population above the age of 80, which has been vaccinated in China. And as Andrew said, probably with vaccines which quality can be discussed, can be disputed. So if they open the door, if they try sort of halfway house policy, they're going to do it against the most vulnerable part of the population, benefiting from a very, very low level of protection. And that's clearly a gamble that GE, for the time being, is not ready to make. So they keep with the zero-COVID policy for the moment, because we don't know how it would be socially acceptable to do otherwise, and we are afraid of the actual effect on mortality. What does this leave us? Some of you may have seen the latest surveys in China. It's starting to look like the sort of abysmal readings that we had in Western countries 2 years ago. The PMI fell to about 36, if I remember correctly. It's looking pretty bad in terms of economic activity. If we look at the capacity of China to continue to meet global demand, exports in March were still okay. We don't know if that continued in April. And that's maybe another installment of the crisis, in the sense that we thought 2-3 months ago that this gigantic disruption to supply lines was starting to go away. If China continues with zero-COVID policy, which seems to be the case, it's highly likely that they won't be able to meet global demand. And that's my final point. At the very beginning of the pandemic, and that's the first question, Olivier, you asked Andrew about the capacity to how the American system was responding to the crisis, and we had this issue with supply. Truth is, without China, the developed world would not have been able to deal with the pandemic at the beginning. We imported most of our supplies to fight the pandemic at the beginning from China. And at the beginning, in the first 3 months, we had endless speeches and discussions about the need to repatriate production and to deglobalize. We're doing exactly the opposite. If you look at the share of China in European imports today, they are still significantly higher than before the pandemic. So we've done the opposite. We've made ourselves more dependent on Chinese production at a time when, unfortunately, Chinese production is probably going to be impaired again. So, as is usual for me, I will end up with some doomsday prediction, at least for the second half of the year. Disruption to supply lines is, unfortunately, likely to come back or to become more acute in the second half of the year. Welcome to Brave New World.
Thank you. Maybe we have time for 1 or 2 questions from the audience. So first row, Marc-Olivier, so the mic is coming.
Thank you very much. The panelists were right to focus on advanced economies, and Olivier extended that to China. Can you say a little bit more about the other emerging economies and the developing countries who do not have as much access to fiscal policy and debt? And in a globalized world, this would have an impact. And second, I was reassured by your Gilles, on the way it was dealt with in 2020-21. But making a parallel with long COVID, don't you think that there are scars? I'm a teacher in the skills of people, in the capacity to go into the labor force participation and possibly a more polarized world. How much is that a trouble, and do we know how to cure long COVID and that type of problems?
Gilles, this is for you.
Yeah, on the developing world and emerging nations, again, I remember at the very beginning of the pandemic, there was a lot of expectation from the IMF on extending new facilities to make sure actually that the countries, that the poorest countries could actually deal with the pandemic. To some extent they did. I mean, new weapons were put in place, or instruments were used at the time. Was it perfect? Absolutely not. And what we get in terms of from our operations, for instance, in a number of developing nations, is that in truth, when faced with the choice lockdown versus allowing the pandemic to expand, a lot of countries really had no choice, because lockdowns in reality meant having people literally starving. So they allowed the pandemic to extend. Would this happen again if there's a second outburst? Unfortunately, probably yes, because the amount of international solidarity has not been up there, and has not been sufficient. And I think it's fair to say that. On the scaring for the younger generation, I think a lot about this. One, I know it's trivial, but I think it's very, very true. The generational inequality in the face of remote working, it's obvious to me that it makes the capacity of younger workers to integrate, to learn by doing, to benefit from the experience of their older peers. It's clear to me that it's much lower in the new system. I don't have any clear answer to that, but it's absolutely obvious. It's a bit better now that we have 2 or 3 days collectively in the office, but it's definitely not perfect. As to the scaring effect on wages, and I speak here as a late boomer, because I had the misfortune of starting to work, of graduating in 1992, so just on the eve of one of the worst recessions before the pandemic one. And the employment rate at the time was actually much higher than today. This was a very interesting natural experiment to look into the impact of having the misfortune to start your career on a recession year. The negative premium on your wages can last for 10 to 15 years. And in some cases, actually never disappears. So we have a generation, a cohort of people who started their career in 2020-21, who are at a disadvantage relative to their peers. They started at the wrong time. And there's also nothing easy to do, but they've started at the wrong time. And that's true as well, possibly on the quality of teaching in universities which have been operating in remote for 4 years without providing the sort of generic learning by doing experience. Hopefully, this is going away, but there's a generation that has been sacrificed. That's quite clear.
I just wanted to call our attention to another aspect of the implications of this. It hasn't to do with long COVID, because I'm on the part of the spectrum that doesn't believe that long COVID is going to have a huge impact. Having said that, in the United States alone, the estimates are that 1 out of 500 children have now been left parentless as a result of this pandemic. 1 out of 500. That's the mean. And there are subpopulations in the United States where that's 1 out of 160. That is a permanent impact on someone's life trajectory, permanent. What the implications of that will be when you lose a parent or a caregiver as a child, on the long-term implications with regard to workforce, with regard to involvement in the criminal justice system, with regard to educational attainment. These are enormous, enormous possible consequences that I don't think we have begun to take a look at yet.
Thank you. Since we are running out of time, I think we will stop here this very interesting discussion. What since I'm an economist, I will say I can draw kind of two-handed conclusion. Economists always say on the one hand, on the other hand. My conclusion, on the one hand, both, I would say, you said that long COVID maybe will not be a major problem for the people. And I understand also on the economy, you said the scaring effects are maybe less important than we were expected initially. So, but on the other hand, and this is the negative, what I understand is that both the ability of the healthcare system, of hospitals, or on the side of economic policies to deal maybe with the next crisis, be it a kind of new virus or whatever, will be, I would say, diminished. And you say maybe we have done not too bad the first time. Even the Gilles graded A plus, but next time maybe it could be more difficult. So thank you. And so I think we will have only a very short break to move to the third session on climate change and central banks. And also, I remind you that at 4 p.m. we will have the privilege to welcome Sergei Guriev. For those of you who don't know Sergei Guriev, Sergei is a professor at Sciences Po. He is one of the most distinguished Russian economists, and so he's, I think, one of the best experts to talk about the implication of what's going on in Russia, the economic implications, and the effects of sanctions, and so I will have the privilege also to interview Sergei. So at 4. So you have. So please stay with us, and so we move to the next session. Thank you.